Good afternoon, ladies and gentlemen. First and foremost, I would like to thank IAGES for giving me this opportunity to talk about this interesting topic, ERAS. And I'm going to start off by giving you an overview of what ERAS is. ERAS stands for Enhanced Recovery After Surgery. What it is it's a set of standardized protocols and procedures that's applied for any surgery. I mean, today, of course, we'll be talking about colorectal surgery, but then this concept can be applied for any surgery. And the idea is to improve the patient experience and the outcome. It's all evidence-based. The protocols that have been formulated by the ERAS societies are based on number of papers across the world, and it's a multi-modal approach that is emphasized in the ERAS protocol. And the main focus of all these aspects, which you will see in the next few minutes, is stress reduction and return of normal function. No lecture of ERAS is complete without the mention of this gentleman's name and all the work that he has done. He's called Dr. Hendrickkellett. He's a Danish surgeon. He holds a unique chair that's called Professor of Peri-operative Therapy in the University of Copenhagen in Denmark. He's been the pioneer for this concept. He's been working on it for about 30 years or so and has given numerous presentations throughout the world. He has published a number of papers, and because he's traveled worldwide and addressed lots and lots of surgeons and anesthesiologists, he's extremely popular, not just among the surgeons group, but also among the anesthetist societies and groups. He started off his concept of fast-track surgery somewhere in the 1990s, but the real boom of his concept worldwide came in the early 2000s. I remember very well when I was a trainee in the UK, we used to talk a lot about this gentleman and the concepts that he came with, and we've always tried to implement many of the practices, many of the concepts that he came with in our institution. Of course, when you come with anything new, which is challenging the time-honored practice, age-old practice, you're bound to face challenges. Hendrickkellett also faced a number of challenges, but somehow, as time went on, with a lot of evidence accumulating, he's managed to convince the surgical community about the benefit of ERAS. As I said, although the concept was started in the mid-1990s, a formal study group was formed in 2001. It's a study group of both surgeons and anesthesiologists. And from that time onwards, the study group has been publishing regular guidelines and protocols. In fact, right now, we are following the 4th version of the ERAS protocol. And that's just 4 versions in a period of 17 or 18 years. The first Congress was held in 2012 after the formation of an ERAS society in 2010. So the society is actually based in Stockholm, Sweden, and the first Congress was held in France. And from that time onwards, there was no looking back. There's been an increasing number of centers wanting to adopt this concept. And although Hendrickkellett did most of his work in colorectal surgery, ERAS has expanded. It's expanded to gastric, esophageal, bariatric, pancreatic, and even the non-gastrointestinal surgeons. I know there are lots of papers about ERAS and orthopedic surgery, for example, total hip replacement, total knee replacements, etc. So what is the rationale behind this concept, ERAS? So to understand the rationale, we need to understand a bit of physiology. And I've tried to summarize it in the simplest possible manner. I'm a surgeon, and I'm sure all of you in the audience are also surgeons. So we're not going to go into the details of endocrinology, physiology, and critical care, but we're just trying to, understand in general about what happens during surgery and what ERAS does. So we all agree that surgery is a is something that causes stress to the body, and the body responds to stress in a catabolic fashion, and that's well understood science. There's nothing new about it. So when this stress response occurs, there's a variety of hormones and inflammatory mediators that are secreted in the body, and lots of changes happen. But the most important change is what is called insulin resistance. Because of this resistance, there is hyperglycemia and there's a reduction of muscle glucose uptake. And this leads on to reduction in the lean body mass. And that has a big impact on the recovery of the patient, because the muscle loses its power and it has an effect on the post-op mobilization, it has an effect on post-op breathing, and so on and so forth. Ironically, the non-insulin sensitive cells, like the fat cells and the cells of the cardiovascular system, they take up more glucose, when this situation of insulin resistance occurs. And that increases the chances of infections and cardiovascular problems and so on. So basically, ERAS, it attempts to bring down these physiological responses and bring about a big change in the way in which the patient recovers after a major surgery. Why is it important in colorectal? Well, we know many of our colorectal surgical patients stay in the hospital for a long period of time. Post-op nausea and vomiting is a common occurrence. We do see surgical site infections from time to time, and these are fairly expensive operations, particularly if they are long operations and involve lots of instruments and so on. And there is a small but significant readmission rates with colorectal surgery. And therefore, the earlier interest, many of the papers that were published in the earlier part of ERAS were all on colorectal surgery. So what is it that we're trying to understand and trying to improve as a result of this ERAS? Well, basically, it's 5 things. You want the patient to be completely free from nausea and vomiting. You want the patient to be pain-free, at rest. They're not entirely pain-free. They've had a major operation, but at least when they're lying down, when they're sitting in a sofa, they should be comfortable. The bowel function should return back to normal. There should be no problems with wound infections, and the patient should get out of the hospital as early as possible. So to implement the ERAS protocol, there are a number of interventions that have to happen, and it's a package. All of it need to happen together for us to see the maximal benefits. And I've categorized them into preoperative interventions, perioperative interventions, and postoperative interventions. So preoperative intervention, as you can see there, the first intervention that's mentioned is the counseling, pre-admission counseling. So that's an indication that when we prepare our patients for ERAS, we don't start thinking about it from the time the patient gets admitted into the hospital or from the time the operation commences. Not at all. It starts days before the hospital admission, sometimes even weeks before. The patient is thoroughly educated about what the operation entails, what to expect, what sort of complications might occur. It gives them that psychological advantage over somebody who's not been informed all of these things. So they're prepared mentally. If they're going to have an ileostomy, the ileostomy site is marked, they're told how to use it. Most importantly, they're told about the problems that the ileostomy can cause, particularly the problem of dehydration. After they get admitted, standard conventional practice would be to keep the patient nil by mouth for 8 hours, 10 hours, sometimes overnight, might even go up to 12 hours. Not so in ERAS. They are given a clear liquid diet up until 2 hours before the general anesthetic. And there's something called carbohydrate loading, oral carbohydrate loading. They are given complex carbohydrates, drinks, up until 2 hours. The idea being this carbohydrate drink, it brings down the catabolic response, not just during surgery, but also during the fasting phase. So if you got to look at it wholesome, the catabolic response for that surgical patient starts even before the incision. He's fasted for 8 hours, 10 hours, and then you've given him a surgical stress. So these are the things that Hendrickkellett attempted to address, and I have to say he's been very successful in this venture. And there are lots of things that have been studied ever since, and the evidence is accumulating. The other things, of course, you optimize them. If they have any comorbidities, get all their medications sorted out, and get them to stop smoking at least 4 weeks prior to surgery. And also get them to stop alcohol if they can, but if they can't, at least get them to minimize the consumption of alcohol in the weeks prior to surgery. Surgical site infection is a common problem, unfortunately, and it causes a lot of morbidity, because it's physical morbidity as well as psychological morbidity, if you like. It's not a nice feeling for a patient to have a wound discharging pus, to have a gaping wound or whatever. See, you may have done an excellent operation inside the abdomen, but then the patient hasn't seen that. He's not able to see that in the postoperative period. What he sees is the abdomen, is the skin. And when that breaks down, it's not a nice feeling. It causes a lot of psychological trauma, and it adds to the cost and the hospital stay too. So ERAS has come with a set of protocols that have to be followed to prevent this. Get the patient to have a chlorhexidine shower on the day of surgery. Try to, well, in general, if it is a colonic surgery, you could avoid bowel prep. But if you were to give bowel prep for a specific reason, or if it was a rectal surgery, mechanical bowel prep with oral antibiotics is the choice. Give them a broad spectrum antibiotic an hour before incision. You prep the skin with chlorhexidine. Use a wound protector, and if possible, try and change your gown and gloves before the fascial closure, and have a dedicated wound closure tray. Most importantly, keep the operation room traffic to the minimum. Opioids are never helpful in the ERAS setting. So if you want to have adequate pain relief, plus have all the benefits of ERAS, you got to switch away from the opioids. And the recommended combination is paracetamol with non-steroidals, with local infiltrations of the ports or the wound, depending on whether it's laparoscopic or open. Tap block. Now, tap block has got this extra advantage of giving you an opportunity to operate even at a lower pressure pneumoperitoneum, because it tends to relax the abdominal wall muscles. Thoracic epidurals, it's great, but the ERAS protocol suggests that it's not always essential if you're doing laparoscopic work, but if you're doing open work, yes, it is recommended. And as I told you at the beginning, ERAS involves not just the surgeons, but surgeons, anesthetists, and lots of other practitioners who work together for the benefit of the patient. But in theatre, the anesthetist and the surgeon has to work in tandem. The anesthetist should be aware of the medications that are recommended in the ERAS protocol, dexamethasone, ondansetron, gabapentin, to prevent nausea and vomiting, because all of these add up. It is not just one single aspect of ERAS which gives you the excellent outcome, but a combination of things which work together. See, there is a tendency for surgeons and anesthetists alike to overestimate the amount of fluid losses. You've got a big abdomen, you've got an abdomen opened up, bowel is exposed to air for 4 hours, 5 hours. You tend to think, oh, the patient has lost lots and lots of fluids, third space losses and whatever. To some extent it might be true, but then studies have shown that most of the time it is an overestimation, and therefore they end up getting more fluids, and these fluids tend to get into the tissues and cause problems in the immediate postoperative period and in the late postoperative period. So The idea is to stick to a 1.5 ml per kilogram per hour for the patient. On an average, of course, it will vary depending on the weight of the patient, but the target has to be a perioperative fluid balance of 0. And it's extremely important to maintain normothermia during the operation. Hypothermia has been shown to be directly linked with many metabolic problems in the postoperative period and resulting in poor outcome. So it needs to be taken care of. Forming of the anesthetic gases, forming intravenous fluids, irrigation fluids, warmers, blankets, and so on. There is absolutely no doubt a minimally invasive approach, laparoscopic approach, has got an advantage to an open approach when it comes to ERAS, and for that matter, robotics too. If your institution can have a good minimally invasive surgical program, it's great. But then you got to understand, ERAS is not about minimally invasive surgery or open surgery. It's about a set of protocols. It's about a set of standard practices. It is about challenging the olden day practice in order to achieve the best outcome. And it would work regardless of whether you're doing it minimally invasive or open. Only thing is trying to get the compliance, trying to get the entire multidisciplinary team work towards it. Nasogastric tubes and drains are not routinely required. If you watch Hendrickkellett talk, he would tell you he prefers the food to be given for the patient on the first postoperative day in a table and a chair and not by the bedside. He's got a point to make. If the food goes to the bedside, the patient doesn't get out of the bed. Whereas if the food is placed in a table and if there's a chair next to it, the patient will get out of the bed and go to the table and have food there. So there's enormous emphasis on early mobilization. In fact, removal of the urinary catheter is also directly linked to getting the patient to mobilize better. When it comes to IDS, there is enough evidence to say that if you feed the patient early, less than 24 hours, there's a chance that they develop less IDS as time goes on. And that's been proven by some experimental studies as well, wherein sham feeding, as in sugar-free chewing gum was given for patients in the initial postoperative period, and that stimulated the colon, and they had an early recovery of paralytic IDS as compared to patients who were kept nil by mouth. There is a drug called albumin, which is an opioid receptor antagonist, which can be tried. It's a peripherally acting opioid receptor antagonist. But then that's not something that is available everywhere. But then it's something that has been tried in the ERAS protocol and is found to be effective. IV fluids are discontinued after surgery, just as when the patient goes back to his ward, and catheters are removed at the earliest. If it is a colonic operation or an upper rectal operation, catheters are removed in 24 hours time, less than 24 hours time, unless of course there's a colovesical fistula. If it's a mid-rectal or a lower rectal operation, they are removed in about 48 hours time. So in conclusion, we have to understand that ERAS is not one set of guidelines, but it is a continuously evolving set. And as new evidence accumulates, we got to change according to it. The first one was published in 2001. In 2018, the fourth version of it was published. And more and more papers are coming up throughout the world that it is safe and it is feasible and it improves outcomes. It started off in Denmark and then it caught up quite well in Europe and America, and there was a misconception once upon a time that it was for the developing world, for the Western world. But then, if you do a Google search, a PubMed search, you will find that there are lots of papers on ERAS coming up in colorectal, pancreatic, hepatic, gastric surgery from China, from Japan, from the Far East, and from India too. But the challenge is that you got to you've got to sustain that level of compliance, which can be difficult in certain healthcare systems. And also it's quite difficult to have the same kind of blanket rule for all the countries, because healthcare systems are different in different countries. And even within one country, India, for example, we have a variety of healthcare delivery models, and it's not uniform. And it can be quite difficult to ensure that hospitals adhere to a set of protocols. And the other thing, of course, is ERAS is now confined just to elective surgery, elective colorectal surgery. This is not, this doesn't involve into an emergency setting. Whether it's something big like doing the operation minimally invasive as opposed to open, or whether it is something small like just removal of a nasogastric tube within 8 hours or immediately after the surgery is finished, it has an impact. It has an impact on the outcome of the patient, and that's what ERAS is all about. No matter what it is, it has an impact because it's being studied. But what is important is if you just do 1 or 2 or 3 things out of the 20 things of ERAS, it's not going to work. In fact, it might even be counterproductive. There was a lot of criticisms in the early part of ERAS wherein people said, well, you discharge the patient early, what about the readmission rates? And that's because the entire ERAS protocol was not followed. But if it is adequately followed, if all the aspects of ERAS are followed, the readmission rates after the ERAS, after patients were discharged, is the same whether an ERAS was followed or conventional treatment was followed. And there's also there's an understanding, particularly among trainees, that ERAS is all about getting the patients out of the hospital quickly. But that's not. It is not about early discharge, but it is about the ability to achieve various, post-operative milestones. Each of it is a milestone: passage of flatus, getting out of the bed, having solid food, being free from nausea and vomiting, able to be pain-free at rest. Each of it is a mileage, and it is trying to achieve each of it on an individual basis so that an early discharge will be facilitated. Ultimately, the goal is to improve the patient experience, minimize the complications, reduce the cost, and improve the survival. Now, like everything in medicine, if you want to go into the details of what exactly the concept is, you've got to go to the source paper. There are lots and lots of RCTs and personal experiences, institutional experiences about ERAS in the literature. But yes, you can of course go through them, but then I would recommend you go to the source literature, which is this clinical practice guidelines for ERAS in colon and rectal surgery. It's a joint statement, joint guidelines published by ASCRS and SAGES in 2017, and another guideline published by the ERAS Society itself in 2018. This actually appeared in the World Journal of Surgery in 2019. So I would strongly recommend you go and read these papers for more information on what you've just heard. Thank you very much for your patient hearing. Once again, I thank IAGES for giving me this opportunity, and I thank my moderators, Dr. Devi Bhaskar, Dr. Achal Gupta, for this session. Thank you very much.